So I'm just going to tell a little bit of a story around prison needle and syringe programs in Australia, and I think people can take that image on the front on the opening screen and interpret it as you will. But it's been a frustrating journey thus far. How do I advance my? Why is that not working? Oops, sorry, it's just a bit slow. Just like to acknowledge the traditional owners of the land I'm sitting on at the moment, the Boonwurrung people of the Kulin Nation, and acknowledge their leaders, past, present, and emerging, and note that these lands have never been ceded, and also acknowledge the disproportionate burden that incarceration, bloodborne viruses, and drug use and its impacts have on this community. I always like to start these types of presentations around prison needle and syringe programs with essentially what we know to be true. So we know that many people who enter prison and are dependent upon injectable drugs. We know that a substantial proportion continue to inject drugs in prison. We know that most will reuse needle and syringes after someone else. And we know that these settings have the highest clustered prevalence of hepatitis C in Australia and in many other parts of the world. So when we put these four things together, we acknowledge that it's an absolute public health failure that we're unable to provide effective harm reduction within these settings. And we know that this situation is in breach of our obligations under the resolution, the General Assembly Resolution 7175, or the Mandela Rules. That really, it did a lot of things, this resolution, but one of the things it did do was define and strengthen the principles of equivalence of care for people in custodial settings. And rather than, prison NSPs being painted as something that is advocated for by the loony left, which is often the way it is portrayed, we know that prison NSPs are endorsed by a range of Australian organisations and professional bodies, medical professional bodies, and also internationally across the world, those organisations listed on the right-hand side. So it is not, while it's often seen as something that's radical, it is actually evidence-based and endorsed by a range of professional organisations. And in terms of, the breach of the UN resolutions, while 87 countries provide NSP in the community, only 10 provide NSPs in prison. So essentially all of those countries in the light blue are in breach of that resolution. And I would argue that some of the dark blue as well in relation to the level of coverage of prison NSPs in some of these countries. It's a pretty low bar to have at least one needle and syringe program in one prison in your country to be classified as, to be, one of those dark blue bars, when we know that the coverage of the NSPs in the community is far more significant than that. And I just want to do a little bit of a storytelling about prison NSPs in Australia, particularly when we got really close, but, as I've written there, but no dice. And the, paraphrased title of this sort of story is how we got rolled by the CPSU. So the closest we've come to a prison NSP in Australia is through the Alexander McConaughey Centre. So prior to the establishment of the Alexander McConaughey Centre, the ACT also signed off on a human rights charter, which meant that it was the perfect place when this prison was commissioned. It was the first and remains the only prison in the ACT. Prior to this, people from the ACT were incarcerated in New South Wales. It was the perfect place to consider a prison needle and syringe program. And according to the ACT Health in 2008, the Alexander McConaughey Centre will embrace a best practice evidence-based correctional health model that provides services equal to those available in the general community. So this was a pretty exciting statement. And we thought, this is laying the groundwork for Australia's first prison NSP. And indeed, the Chief Minister, John Stanhope, at the time, opened the door publicly to this idea that the revolution is coming, and this is the place that we will establish the first prison needle and syringe program. Unsurprisingly, the unions, as they have historically leading up to this point, were up in arms and gathered some media attention in terms of saying we are dead against this idea. So this is sort of, what I think is the first failure of process in terms of, public policy from the ACT government, that there were plans to pretty well open the Alexander McConaughey Centre with a prison NSP as part of it. Given the union issues, they squibbed on that commitment. I'm not sure if it was a commitment in writing or an implied commitment. Instead, they said that we will have a full and comprehensive evaluation of drug policy and services across the first 18 months of operation, essentially to see if a prison NSP would be needed in this setting. Something that we all thought was, pretty bloody obvious and would not need an evaluation of drug policy and services after 18 months. So this tender was issued to essentially do that evaluation of drug policy and services, for which the Burnet applied. Stuart was at the Burnet at this stage, but was a part of the advisory committee advising ACT Health, so he obviously could not be a part of the evaluation. But myself and our team at Burnet applied, and we were successful in this tender. I have to say it was very well thought through and very well planned, and every representative was around the table in the hope that if everyone's around the table and informing this process, that it would be a way of getting the outcomes of the evaluation actioned. So that we could potentially have a prison needle and syringe program. And I've circled there, it absolutely included the CPSU at the table, and we were hoping to have them a part of the decision making and informed of the evidence around the final decision would help break the union impasse. Even though this was about drug policy and services more broadly, the elephant in the room was always prison NSP. So the findings of the evaluation, we had quite a large report because it had to cover all drug policy and services, but in relation to some of the findings around drug use in prison, the evaluation found a high prevalence of in-prison drug use, drug trafficking was occurring, supply reduction activities were disrupting but not halting supply. There was diversion of prescription medications, and the transmission of disease was occurring. We probably could have said all of this without such a broad-based inquiry. Therefore, recommending that a prison needle and syringe program should be implemented at the Alexander McConaughey Centre. The aftermath was, I'm going to say, it was essentially a bit of a shit show. There's a large amount of media attention, some of which related to needle and syringe programs, some of which related to, the leaking of information and the trafficking of drugs, and the implication that some staff and correctional services people were involved in that trafficking. At the time, unfortunately, there was an EBA that in the ACT that was being stalled by the CPSU, who demanded that the prison needle and syringe program be taken off the table, and the government was a bit wedged on this issue. The government was committed to implementing a needle and syringe program, but acknowledged the need for this to be developed with input from the ACT correctional staff to recognise the genuine concerns. So, so the unions became involved in, through a deed associated with the EBA, that a model would be determined for the NSP, and that would be put to vote to the rank and file of staff at the at the Alexander McConaughey Centre. But this was really the start of a long stonewalling exercise by the CPSU. So this was the deed, the side deed that was put beside the signed EBA. And I circle a couple of things around, firstly, that parties will act in good faith. And I'll return to that, so-called good faith commitment that everybody made. And that the parties would agree that a proposed model will be put to vote. So to develop the model for the needle and syringe program, they started a process where they called upon select experts around the country to provide submissions around what a needle and syringe program would look like so that that model could be put to the rank and file for vote. So this is the front cover of the submission that we made to the from the Burnet Institute. And this model actually relates to what Farah will be talking about later, because it's essentially, we picked the eyes out of this model, which I still believe is a best practice model. And that is what's costed in Farah's analysis. And in summary, it's essentially a one-for-one multi-pack exchange through health staff who would request, attendance at the Alexander McConaughey Centre Medical Centre. Essentially the same as most needle and syringe programs in countries in Europe, sort of modelled on both Switzerland's and Luxembourg's successful models that have been running for decades now. And essentially the principles, I think, around an acceptable prison needle and syringe program that is both acceptable and effective needs to be this balance of institutional control and risk management to ensure that all the stakeholders in prisons buy into it, and because there are so many of those stakeholders that can undermine the fidelity and the success of a needle and syringe program. So we do need to pay attention to that on the left, but it also, to be effective, needs to be low threshold, so that people can access it freely and without fear of stigma, discrimination, and sanctions related to access. So that's so we need to balance that risk management for the good working order of prisons against a program that is actually accessible and effective. Unfortunately, my model did not get up as the selected model. What was put forward was something that came from the Public Health Association of Australia, which is essentially a medically supervised injecting room, similar to part of what exists in Canada at the moment in terms of their sort of hybrid model. I believe they probably went with a model like this because they thought it would be more acceptable to the rank and file, because all of the needles and syringes then get contained in one physical environment and are not sort of distributed around the prison. So what was the result? It got put to vote, and 97% of the rank and file at the Alexander McConaughey Centre voted against. The union said that this goes back to my point around good faith, had listened to stakeholders like the PHA and considered all the evidence in weighing up their vote. I know for a fact there were, on the back of toilet doors, that's for staff at the Alexander McConaughey Centre, and everywhere there were posters advocating for people to vote no on this. So, the notion that everyone acted in good faith is questionable. And I would even argue that the independent committee that was set up to decide on what model went to vote, I think are partly complicit in this as well. And the reason I say this is that they directly asked me to provide contacts to countries in Europe that had implemented prison NSPs, because the committee would like to talk to them about how it was implemented. I gave them numbers and email addresses and said, I've worded them up. They know that you're going to be in contact. I then received an email from one of my colleagues 6 months later asking, what had happened to the committee reaching out. So they had never actually followed up on that request. And I would argue that the committee itself was somewhat compromised in relation to supporting the notion of a prison needle and syringe program getting up. And that basically killed it. That was pretty well a 5-year process of trying to get a needle and syringe program established at the AMC. And that's why I sort of talk about, we essentially got rolled by the CPSU. They played a long game and probably a pretty smart game, but eventually they got what they wanted, and that was the end of it. And that was the last and closest chance that we got. So where to from here? Look, we can continue to write and advocate for. We need to talk to politicians and key stakeholders. So this is the draft of this was the draft, consultation draft for the last strategy for viral hepatitis and bloodborne viruses and STIs. And there was that statement there in the draft policy that the new hepatitis C strategy is due to be released soon. And my understanding is while there is a statement along these lines, it has been watered down substantially. I'm not 100% sure of the wording, but there was a viral hepatitis strategy from a few years back that explicitly called for a trial of a prison needle and syringe program. We need to keep advocating for those types of inclusions as evidence-based approaches in national strategies. Another strategy that's been spoken about is inviting people from correctional officers from other countries to come to Australia and to talk to our correctional officers in Australia about how the models have been successful elsewhere. Basically, a peer-to-peer sort of approach. I had scoured Europe looking for those types of people. One of the challenges was people who would be who are competent English language speakers and who are in correctional services, who could advocate for needle and syringe programs in their countries and in Australia. Canada became the first English-speaking country to implement needle and syringe programs recently, so there is definitely some opportunity there. So they've implemented across federal prisons, 9 federal prisons. I think it's expanded slightly since I put these slides together. One of the problems here is that the current uptake is very low, and we have a NIH-funded research project at the moment, implementation science research project to get this happening. So it's essentially, a lessons learned approach, that the sky didn't fall in, and that those stories could be told to correctional services officers in Australia. One of the main problems I see with this, however, is that the UCO, the Union for Correctional Officers, I think in Canada, is like the CPSU. They are dead against this, and they want the prison needle and syringe programs removed. And in fact, they sent Christmas cards to Canadian politicians with a Christmas tree adorned with needles and syringes, telling politicians that this was endangering their occupational health and safety. So they are very against this, and part of the reason was that a careful implementation approach was not conducted in advance of this. In fact, it's a side story, but the prison needle and syringe programs were implemented with, or the decision was made with almost no consultation or notice given to to the officers. So even if we were to find some correctional officers that would speak on, positively about the program, international unions speak to each other, and the CPSU would know that, those individuals had been cherry-picked and would argue that they are not representative of the concerns of officers in Canada. But I think the real key on where to from here is political will. The story I've just told showed that even a progressive jurisdiction like the ACT ultimately squibbed it and failed to back up the political will that they had. Katie Gallagher, after our report, announced that a prison needle and syringe program would be implemented in Canada and in Canberra, and ultimately, that did not happen. And I often use this paraphrased quote because I was scribbling it down in the session. I'm not sure if it's word for word what Mercedes Lamas said at the World AIDS Conference in 2010, but someone asked her in the audience, what was the thing that got Spain over the line in terms of prison needle and syringe programs? And she essentially said that the politicians needed to understand that drugs in prison was not their political failure, and that drugs in prison happened because of a failure of the war on drugs. All of the things I had at the early on in the slide that we know to be true around the incarceration of people dependent on injectable drugs, and that then creates a commodity and a market, and anybody who's spent any time around a large correctional institution knows the amount of movement that needs to happen in and out just to operate prisons. And it is inevitable, therefore, that drugs can get into prison. No, I'm not aware of any prison around the world that is drug-free. So, the political recognition that drugs in prison are an inevitable product of criminalising drug use and incarcerating drug users is a precondition to a mature conversation about how to reduce drug harms in prison. So this is not your political failure. Unfortunately, this is a complex argument to prosecute in the community. So politicians are obviously still extremely nervous about this type of policy action. There are no votes in prisons. There are no votes in drug use and tolerating drug use. So it's a very vexed position that politicians are in, but they need to be able to prosecute, and we need to be able to prosecute an argument like this. So I'll just end it there as a sort of intro to another area that we can also work on is ultimately, whenever you speak to a government department, Treasury is king. And one of the ways we can convince governments that prison needle and syringe programs are a good idea is that they're cost effective, and they will actually save government money. So on that note, I'll pass on to Farah.
Yes, thanks, Mark, for laying the groundwork and setting the scene locally. It's my great honor to present this very important work that we conducted last year, which is estimating the return on investment for a prison-based needle and syringe program in Australia. I would also like to start by acknowledging the Bunurong people of the Kulin Nation, the traditional owners of the land I am on today, and pay my respect to elders past, present, and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples with us today. I might skip on the background slide because Mark provided a lot of this information in his talk, and go straight into the modeling that we conducted. So we sought to provide kind of an additional economic rationale for the introduction of prison-based needle and syringe programs in Australia. And we wanted to estimate the impact of such a program on the number of hepatitis C infections and hospital admissions for injection-related infections in prisons. We also wanted to calculate the economic benefits and the benefit-cost ratio of a potential prison NSP in Australia. To do so, we ran two different scenarios. The first one is the status quo, where hepatitis C testing and treatment in prison is maintained, but there is no prison needle and syringe program. And in the second scenario, we assumed that needle and syringe programs would be implemented over a 2-year period across all prisons, with coverage increasing linearly to reach about 50% of people who inject drugs in prison by 2030. We developed a stochastic compartmental model that included the entire prison population in Australia. That was around 42,000 individuals in prison in 2023. Individuals could enter the model based on the annual number of prison admissions, which was 68,300 in 2023. And they are classified according to their injecting drug use status, as well as their hepatitis C RNA status. And so we use data from the STOP-C study. The study is a prospective study within a cohort of people incarcerated in 4 prisons across New South Wales. And their data showed that 56% of the prison population have a history of injecting drug use. And among those, about 66% continue to inject while in prisons. In the model, we also assumed that the hepatitis C RNA prevalence among those entering prison with injecting drug use history is the same as the prevalence among people who inject drugs in the community, which decreased from 51% in 2015 to 12% in 2022 due to the scale-up of hepatitis C testing and treatment. And people who inject drugs in prison have a probability of becoming infected with hepatitis C or experiencing an injection-related infection. So these are the red and orange arrows on the diagram. And the incidence rate for hepatitis C in prison was around 22 per 100 people who inject drugs in prison per year between 2014 and 2017. Reducing to about 10 by 2018-19, also due to testing and treatment scale-up. The incidence of hospitalizations for IRIs or injection-related infections was estimated to be 3.1 per 100 people who inject drugs in prison per year. In the model, individuals that are infected with hepatitis C have a probability of getting treated based on the annual number of treatments in prison, which was around 2,000 to 3,000. And these are the black arrows on the diagram. And finally, in the green arrows, you can see the impact in the model of the prison needle and syringe program. So it would act by reducing the probability of experiencing an injection-related infection or acquiring hepatitis C. The costs were calculated from a health and correctional systems perspective and were estimated using an ingredients-based approach. We included costs related to program startup. So these covered an initial 1-hour training session for healthcare and prison staff, and we assumed a 24% annual staff turnover. We also considered one-off initiation costs for participants. So these are costs for their first health service visit and for receiving their first initial kit. And also costs per unit, such as staff time for managing the kit exchanges and the cost of the kit components themselves. We also considered annual operational costs. These are ongoing expenses such as staff time to order the supplies, as well as shipping costs. For the benefits, we estimated the averted costs of treating hepatitis C infections and injection-related infections in the hospital that were prevented. So for the cost of hepatitis C treatments, we took those from the pharmaceutical benefits scheme, and it was estimated at around $36,000 per course. But we tested $5,000 and $15,000 in sensitivity analyses. And for the cost of managing an IRI at the hospital, that was estimated to be around $13,000 using the National Hospital Cost Data Collection Public Hospitals reports. And finally, the benefit cost ratio was defined as the ratio of total benefits to the total costs of the program. Essentially, if the benefit cost ratio is greater than 1, that means that the total benefits are greater than the total cost, and therefore there's a positive return on investment for the program. So the model was calibrated to the prison population size, that's the top left figure, and the estimated prevalence and incidence of hepatitis C and injection-related infections in prison. The top right figure is the IRI incidence in prison. The bottom left is the hepatitis C RNA prevalence, and the bottom right is the hepatitis C incidence. And the blue lines represent our model outcomes, while the black circles represent kind of the data or the estimates that we have. And you can see as well that we have some shaded areas around the lines. That's because we ran about 500 simulations to get a wide range of possible outcomes. So on to the results. Again, in the figures on the right, the blue lines represent the status quo scenario, and the red lines, the prison needle and syringe program scale up. The top figure is the incidence of hospitalizations due to IRIs, and the bottom is the hepatitis C incidence. So we found that between 2025 and 2030, the status quo scenario resulted in 2,932 hepatitis C infections and 3,110 hospital admissions for injection-related infections. The hepatitis C incidence rate in 2030 was 3.1 per 100 people who inject drugs in prison per year. Just as a reference, the WHO has set hepatitis C elimination targets for 2030 for less than 2 infections per 100 people who inject drugs per year. The scale-up scenario over that same period averted 890 hepatitis C infections and 522 hospital admissions due to IRIs compared to the status quo scenario. In the scenario, the hepatitis C incidence in 2030 decreased to 1.3 per 100 people who inject drugs in prison per year, and all of our 500 simulation reached that WHO incidence target of less than 2 per 100 person years. And compared to the status quo, the prison needle and syringe program, which would be expanded to all prisons across Australia and reaching 50% of people who inject drugs in prison, would cost approximately $12.2 million, but would save approximately $31.6 million in averted healthcare costs. So that results in a benefit cost ratio of 2.6, which means that for every dollar spent on prison needle and syringe programs, $2.6 could be saved from hepatitis C and IRI treatment costs. And the majority of the costs are associated with activities related to the distribution of the kits, while the majority of the benefits are associated with the cost of hepatitis C treatments averted. But the sensitivity analyses showed that even if the treatment cost for hepatitis C was around $5,000 as opposed to over $30,000, the benefit cost ratio would still be favorable. Now, our study is not without any limitation. First, we had to estimate the costs of a prison needle and syringe program since they do not currently exist in Australia. We also used the same parameters for all prisons across the country, and that's due to limited disaggregated epidemiological and behavioral data. Also, our model may have failed to capture the full complexities of needle sharing behaviors or transmission risks. We may also have underestimated the benefits of a prison needle and syringe program because we did not consider, for example, severe disease prevented from hepatitis C infections averted. We did not look at the onwards transmission prevented in the community post-release or the reduction in hepatitis C outbreak risk in the context of elimination. Also, when we estimated the cost of IRI treatment, we excluded low-level infections that are treated on site. And we did not consider the impact on other bloodborne viruses, nor the opportunities to link with treatment and other health services. Finally, globally, there have been implementation challenges, and these could be overcome with design consideration that will maximize program participation. So the key takeaways in Australia, the implementation and the scale-up of a prison needle and syringe program to reach 50% coverage among people who inject drugs in prison by 2030 could prevent 30% of new hepatitis C cases and 17% of hospital admissions for IRIs over 2025 to 2030. Australia is unlikely to achieve the WHO incidence target of less than 2 hepatitis C infections per 100 person years among people who inject drugs in prison without a prison NSP. However, this target is easily within reach with the program. And finally, every dollar invested in prison NSPs could save more than $2 in averted hepatitis C and IRI treatment costs. And this aligns quite well with previous work that estimated that NSPs in the community in Australia had a benefit cost ratio of 1.3 to 5.5. Yes, thank you to the entire study team, as well as the Sub-C study group for providing us with some of the data that was needed for the model, and the staff involved in the Canadian Prison Needle Exchange Program.
Thanks so much, Farah and Mark. That is a real shame that the program didn't get up in the ACT, given the return on investments we see from your modelling. I'll just open it up to questions. So just raise your hand if you have any, or put them in the chat. I might just ask a question first. I sort of skimmed through the paper earlier today, and I'm not an economic modeler, so also tell me if my understanding's wrong. But I saw that you, I think you assumed that for everyone engaging in the program continuously, they would not be sharing needles. Is that what we see in, when the programs are actually rolled out? Do people who engage in it not share them at all?
That's a good question. Look, we explored in the appendix and supplementary material different relationships between the coverage and the reduction in risk. For simplicity, in a perfect world, we did assume that those who participate in the needle insurance program do not share. That eliminates the risk of sharing. However, in reality, I am not sure that this would be the case, which is why it's one of the limitations that we may not have captured the full complexities of needle sharing. So I can't say that this is, but it was explored in the appendix, and I think even in cases where the risk is not eliminated, we still have a favorable outcome, but we just don't have the data to really support it in the model.
Yeah, great, thanks. Stuart?
Yeah, Mark and Farah, thanks for a fantastic presentation. It was a great tag team, Mark, with you. You obviously know this area back to front and inside out, and then Farah with your technical expertise. I've got a kind of a technically impacty question, which is just about the return on investment. And I think one of the challenges I see in this area is not always think about payer perspective. So, if we've got corrections and or a state Department of Health spending the money, and to the extent that the savings are in hepatitis C treatment costs, which are incurred through the PBS, is there a bit of a tension there that you have the states and territories spending money to save the Commonwealth money?
Yep. No, yeah, that's absolutely the case. I guess, that's one of the challenges of our federated system. Can politicians be convinced to, think about the greater good for the country as opposed to whose money is being saved at any particular time? But and Farah's been involved in some of our hepatitis C modelling as well for the Commonwealth. And, there is that tension between money saved through Commonwealth programs versus state-based programs. So that's absolutely acknowledge that. Farah, did you want to?
No, I think you said it all, Mike.
Louise?
Yeah, I was sort of thinking about that point as well. And I was wondering if, when you looked at the international take-up for NSPs in prisons, did you see any, or do you have any observations about the payer model and, the sort of whether they tend to be more in particular types of administrative systems where the paying and the costs are kind of borne by the same entity? Or I know that might be a difficult question, and obviously Canada is a federated system, but I noted that the examples were from the federal prisons, and I did wonder if that might be because the benefits are seen as more directly returnable to the federal health payer, but I don't know enough about the Canadian system to know if that was true or if you had any thoughts on that.
The Canadian, I actually think it was because it was a Canadian federal government decision around, essentially the lead up to this was that the Canadian government was being sued, around not having needle and syringe programs and hepatitis C cases being accrued by individuals. So that action was against the Canadian government, and they fully expected to lose. And they actually jumped the gun on the decision, so they didn't want to seem reactionary and said, okay, we're going to implement needle and syringe programs. And that's sort of part of the problem with their coverage now, is that they didn't do a careful implementation process. They just sort of announced it. And then after a couple of days later, they actually, or the Canadian government, or the people bringing the case actually lost the case. So it was ironic that that happened. So I think part of this is pragmatic on the basis that the decision was made by the defendant, the federal government of Canada, and they have direct control over the federal prisons. And there is in Canada, federal prisons, people who are serving sentences of 2 years or more are housed in federal prisons, and shorter sentences are in the provincial prisons. So I think it's just an artifact of that as to how that happened. I don't think it was based on any payee sort of role. I think that's where the cost benefit is likely to, that's where the underestimate, I think, probably comes. Global hepatitis C elimination is really prefaced off the basis of a treatment as prevention approach, or at least that has given momentum to the elimination program, but it has to come with high coverage harm reduction. And we know that prisons are the engine room of reinfection in Australia. And I think Graham can attest to that in terms of Queensland, partly cursed by the fact that they have such a comprehensive program in prison, correct me if I'm wrong, Graham, 75-80% of all treatments in Queensland are provided in prison, but then that enlarges the risk population for reinfection. So, the reinfections that are occurring in prison are really undermining Australia's hepatitis C elimination efforts. So that, I think that's definitely where, the cost benefit is underestimated.
Yeah, thanks. Stuart?
Yeah, this is kind of a politics question, hopefully a good segue, Mark, from what you were just saying before. I mean, I think the evidence has been compelling for a long time that we should have the same harm reduction measures in prisons that we have in the community. And as you've alluded to, it's all about the politics. And my experience in this environment has been that the correctional officers unions are. Michael Levy and I wrote a little piece on this like 14 years ago, that they're arguably not really serving the interests of their members, and that it's probably in the best interest of correctional officers as well to have needle exchange in prisons. And so I wonder how do we overcome this? And one thing that I know this is very controversial, I'm just going to point to it as a consideration. There's been recent calls in the NT for the Commonwealth government to step in and compel the NT to stop doing such draconian and regressive things in the criminal justice space. I wonder if the argument that the state government's failure to implement evidence-based harm reduction measures in prisons is causing the Commonwealth government to waste a ton of money on hepatitis C treatments that are followed by reinfection might create some political pressure. This is like above my pay grade, but I'm just curious for your reflections.
You would think that would be the case, but in a Commonwealth budget that's I don't know what the total is, close to $1 trillion or whatever, it's probably pretty small fry in terms of. But you're right, it is such a waste of Commonwealth Health Department resources to be continually, shoveling out DAAs to people who are being reinfected in prison. It's I know for a fact that there remains reluctance at the Commonwealth level to push for this. There were, there was a recent release of funds from the Commonwealth around harm reduction in prison, I got a heads up on what that was going to be before it came out, and to say you really should apply. And then what was actually released was a pale comparison of the original proposal that had gone up the pipe, so to speak, and then what came back down was a highly sanitized version of, and was ultimately a harm reduction health promotion exercise, as opposed to any meaningful progression of policy or practice or any formative work that could be done to lay the groundwork for a prison needle and syringe program. So, the irony being is, you have a harm reduction health promotion program for people in prison, but don't actually provide them with the tools to effectively reduce harm. So it was a little insulting to, have a health promotion program targeting people in prison that, basically isn't backed up by any ability to actually reduce harm. So I think that example alone, and I've had recent conversations with, what if, we had a prison site that was interested, and a GM that was supportive? What if, in principle, we had a state government that, in principle would, maybe not, jump up and down in horror at the, what if those two things were true? Would the Commonwealth provide us with some formative, some money to just, I'm not saying to implement a needle and syringe program, but to actually do the formative work, basically an adaptation of the implementation science work that we're doing in Canada, but rather than implementation science to expand coverage, we would do the implementation science approach to how do we implement one. Do you reckon there'd be, and I got to know, even when you put those two things in place and say we're not going to startle the horses, we're not going to use the money to just ram one in, we're just going to do the formative work to understand from correctional officers, from people who are incarcerated in health programs, about what are the key barriers and what are the key solutions. Even then there was reticence to, so that, yeah, it's very, very frustrating no matter how carefully you tread.
Louise?
Just a comment on that one. This might be an impudent suggestion, but I just wonder if you might approach that by going around, approaching it from behind by going, say, through Serco in WA has a very progressive superintendent at Acacia Prison at the moment, who seems to be very interested in exploring some, more progressive approaches, evidence-based approaches. So I just wonder if that might be a way to do it and avoid the whole state Commonwealth kind of complexities and target a particular prison where there's a super who's, keen to try things and interested in collaborating with researchers.
Louise, we may or may not have had a chat with Serco at Acacia. And yeah, I completely agree. Ultimately, I think you still need to get the backing of the organisation that are paying out that contract in terms of WA Health, but there are very sympathetic people there as well. The other thing about Serco is that the primary union is not the CPSU. They are an affiliate, and I'm still trying to work out the relationship between those and whether, if they broke ranks, whether the CPSU would, but I agree. I think ironically it's some of those private privately run prisons where the opportunities exist, because the state system is so, there's so much inertia there that's exerted from, ministers down, and everyone's too scared to do anything. That maybe it is the private prison that, yeah, I agree.
Take the last question from you, Graham.
Yeah, thanks so much, Darcy. This is probably less of a question and more of a statement, but I just wanted to acknowledge actually the work of Mark and Farah and also Stuart in terms of trying to progress this. This is difficult policy space, a difficult research space in terms of trying to get an outcome. And I know that they've been working on it many more years than I've actually been involved in prison health services within Queensland. It is challenging, but I think it's the right thing to do from a public policy perspective. It's the right thing to do from a human rights perspective, notwithstanding all the international obligations that sit behind this. And I just wanted to acknowledge that the patience and the persistence, particularly of you, Mark, in terms of trying to progress this difficult area. And I think it relies on good people, like Mark and Farah and Stuart, to try to progress this and to continue to push for a sensible debate about this. So I just wanted to acknowledge that. It can be quite depressing when you talk about how much effort's gone into this. I know for a short space of time within Queensland, a lot of effort's been gone into it. But I do think that, the important economic arguments, it's really important from a policy perspective to actually have that evidence to be able to say, look, this is what we think it will probably not save, but cost avoidance, irrespective of who benefits. And my argument is, well, who benefits is the whole community within Australia rather than particular governments, because at the end of the day, it's taxpayers' money. And even if we come just to a pure economic argument, it's actually, we all benefit from a taxpayer's point. So I just wanted to make that sort of final comment, is that it's quite easy to have these discussions and be a bit disheartened. But I think, we've got to continue to push and push at all levels in terms of different governments, even conversations with our union colleagues, but also within health in terms of the importance of this.
Thanks, Graham. Very kind of you. And I have said that it's something I want to achieve before I retire. So I hope I actually get there.